Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot.
And today I'm delighted to be joined, as I am every month, by Craig Joseph. He is the Chief Medical Officer at Nordic Consulting Partners. And as we do each month, we're talking about news you can use. Craig, thanks for joining me today.
Thank you for having me. It's a pleasure to be here.
I know I certainly didn't predict, well, maybe I did, but it's still a bit jaw-dropping to realize that here we are some 6 months in and we're still talking about the same topic, COVID-19, and the challenges that we're facing and the latest news. It's a moving target. Latest news, or the big news, certainly from my perspective this month in July, was the change in transmission modality. So tell us what you know about that.
Well, I think the question is really how easy is it to transmit the disease, and how does it work? At first, we had heard that there had to be aggressive hand washing because the virus could live on surfaces, all kinds of different surfaces, for days and days and days. That seems to have fallen by the wayside. Certainly, you can get COVID-19 from various surfaces, but it's a little bit more difficult, and that's probably not the chief way that people are infected. And so it was certainly from respiratory secretions, and people coughing, people breathing, people singing loudly, breathing more forcefully than normal. But I think what you're getting at is the question about aerosols versus smaller, more particulate areas. And I haven't followed the specifics. I think you know more about this than I do, though. What's going on from your perspective?
Well, so it's interesting. One of the things that is clear about this, if anything is clear, is that we're constantly chasing information that's moving in real time, and we keep learning. And you're right, the surfaces, I remember, people with gloves and the whole thing, somebody delivers a package and, you felt like somebody was showing up with
radioactive
level 4 radioactive, unit to your house. And I think we've learned and understood that whilst there is still surface transmission, that's a much lower incidence or effectiveness. And it's certainly person to person, and it's in the air. But the big change that occurred this month was I think the shift from droplets to aerosols. And, most people go, well, what's the difference? They're both droplets. It's a function of size. And the aerosols are smaller sized particles. And the view is that in the case of COVID-19 or SARS-CoV-2 virus, it will stay in aerosol form. And what that means is, and the best analogy I can give you, if you've ever been on a fall morning and you see a leaf fluttering by and it just continues to float through those eddies that keep it floating. That's exactly what's happening with aerosol droplets. They're much lighter, gravity doesn't take effect, and they just remain in the air for a longer period of time. And that changes completely, well, not completely, but a significant change to the guidance around how you protect it. Protection now is you've got to have air movement, and preferably fresh air movement. Interestingly, one of the areas that I think people have been worried about has been elevators. You go into an elevator and suddenly you're with people. Actually, it proves that's less risky than going into a bathroom, which is a closed room with no circulation, whereas the elevator, people walking in and there's a flow of air and you get some movement of those particles, and we're seeing that diminished. The other thing that changes is, as we think about mitigation for this, some of the really interesting ideas put ventilation or taking of air up into the roof area and blasting it with UV, which we know does damage virus particles. I don't think we have solid evidence to know, and there's questions about how much and so forth. So none of this is solid science, but I think we have a good sense of that. But it changes the way that we think about risk. So bathrooms now much more risky. And by the way, don't remove your mask when you go into the bathroom, which I think is most people's sort of, oh, phew, I can take it off. It's a sort of natural reaction. So really a complete shift in the way that we sort of approach safety in buildings, in congregated areas. Now, you put everybody together and, no masks and whatever, you're going to have spread. But if it's, smaller groups and so forth, the risk increases as a result of this aerosol spread because it hangs around for longer.
And so the thought is that droplets fall and are difficult to breathe in when you're standing up and they're near the ground, and aerosols just float.
There's a good visual. I'll try and put this in the accompanying blog post that shows a sneeze, and you can see the different particles in the sneeze. And there are ones that, in fact, I believe I saw, I want to say 20 feet. Was the Mythbusters distance for a sneeze, and that was projectile. But then you get even further distance because those that don't sink down. So the traditional arc sinks down with the heavier particles, but the lighter ones just keep on going, so they can go a long distance.
Yeah. So what could be done? What could you do to decrease the risk? It sounds like if you're inside. Cool. First of all, let's talk about being outside. So the risk is if we could just be outside.
Is great, right?
Yeah, and the reason would be wind
and just general dispersion, because you've got dilution that's taking place in a volume of air that you can't reproduce inside.
And so that's not for those of us that live in a cold climate during the winter. That's not exciting news when we're not able to get outside as much.
I'm just going to say that's true for those of us in a hot climate where it's too hot to go outside as well.
At least I guess it's all in which do you hate more? Do you hate heat or do you hate cold? I don't know. I'm in a temperate area where we have all four seasons, and I think I'm going to be inside a lot more in the winter than I am in the summer or spring or fall. And some things can be done out. You can have meetings outside in the heat under the shade of a tree, but you can't have those meetings when it's 10 degrees outside.
It's funny. I see that the complete opposite way and think I can be outside more when it's cold because I can always wrap up, whereas I can't. There's only so much I can strip off and still be legal.
So I'm not even sure we can continue this conversation, Nick, because obviously what's up is down and what's down is up.
Quite right.
I think we can, though. We can probably agree on one thing. Masks are probably a very good idea when you're anywhere near anyone else.
Absolutely. Mask up, put a face covering on. We might talk about that in a second. But whilst we've got the opportunity, I think important news that came out today, and I really want to get your take on it, is this HHS data takeover, as it's been termed, where they have diverted what used to be the reporting of numbers to the CDC is now no longer going that way. It's going to a brand new site that is, I think, under HHS and the government as opposed to the separate CDC. What do you think?
Well, it's concerning in that, there's lots of reasons for it to be concerning. One is how quickly it came about. So it seems that most hospitals and public health reporting agencies were caught unaware that this was going to be a thing. And so not only are they sending information to a different place and in a different way, but they're actually sending different information. So the formatting is a little bit different. And you might think, well, that's, it's not a big deal. And the information is certainly important, but we have ways of getting this information electronically out of the thousands of systems that folks are using across the country. And to retool that, to create it took years and years, and to retool it is going to take more than a few days or weeks or even months. And some organizations, one that I'm a member of, the American Medical Informatics Association, those are folks that are interested in healthcare information technology and in the how information moves from place to place have come out strongly opposed, actually, and this is a pretty apolitical organization, and put out a pretty strongly worded press release on a few days ago saying that, these changes are actually going to make reporting about public health and make our knowledge of, decrease our knowledge of what's actually going on. So, and that's not even to the point that HHS doesn't seem to be sharing some of the information that CDC shared. So, A, folks are having trouble sending it, and B, it's not being shared as openly, which often leads to, well, if we've decreased transparency, we don't know exactly, we can't double check the data. So how do I know that I can trust the data? How do I know that I should make decisions based on those data points? So it seems questionable. Let's just say that.
So it's interesting. I hadn't thought of it in the perspective that you brought up, and I hadn't even looked to see. I just assumed that, this had been in the making for at least an extended period of time. But it sounds like what you're saying is this is a relatively new concept or idea that has sort of come across and everybody's been caught short.
That is absolutely the case.
Wow.
So yeah, most organizations that were reporting were caught unaware that this was going to happen. And I think we all know there might be a fax or an email that goes out, but so someone knew somewhere. But even if you knew, it's think about something that you've been doing for years, for decades, the same way.
Right.
And someone asks you all of a sudden, or tells you all of a sudden that, oh yeah, that's going to change next week. And we're going to get slightly different information, mostly the same, but slightly different, maybe different formatting, different ways of sending it. What was it, a category that used to be 1 to 10 is now 1 to 15. So you can imagine the downstream effects, like, well, we've had systems in place to categorize this information and send it in a standardized way. And now we're slightly changing some of that information. Is it rocket science to change? No, but these are systems that have been in place for a long time and they take time to change. And we're in the middle of a pandemic, and we're using this information to react. One hopes policymakers are using this information to react. And I think reasonable people can question now how accurate the information is, and B, we're not really seeing the information because it's not being shared and it's not as transparent as it was before. So of course the question is, why would we do this? And the answer is, I don't know. HHS has said that the CDC was a little bit behind and they didn't have the technical chops or manpower. I've heard different stories about why they've changed, but we were never really given a good story about why this has happened. And when groups like AMIA, kind of come out and say, hey, this is not helping and this is going to create, I'm looking at their press release now. We anticipate this shift will create data gaps, hindering efforts to recognize, understand, and evaluate important trends. And so, yeah, it's kind of scary that the government is doing this, and I'm not sure how long until we get back to the point where we can get information that we trust.
Yeah, so for those of you just joining, I'm Dr. Nick, the Incrementalist, and today, as I am every month, I'm joined by my good friend and witty friend, Craig Joseph. He is the Chief Medical Officer at Nordic Consulting Partners. We were just talking about the HHS data takeover. And just for context, I mean, you're extraordinarily experienced in this in terms of producing data and, what it takes. I'm trying to think of a good analogy, and I think ICD-10 is a little bit more than this, possibly. But if you think about that as a project and the shift to ICD-10, what kind of time frame was that in terms of the move from ICD-9 to ICD-10 in terms of preparation work?
That was conservatively, that was about 4 or 5 years,
right,
that folks took to do that. And I wouldn't say that this is certainly not on par with a change like that. And so, it's a much smaller change affecting, fewer folks in the IT infrastructure at the hospital, but we're doing it, and it's ultimately, I'm sure it's going to be a good thing, right? Ultimately, collecting more information. They're collecting information about PPE and ICU beds and staffing and percentages and those kinds of things. Those are all very useful pieces of information. That would be great to have. That said, changing everything on a dime with little notice just opens you up to tons of problems that even if you had the resources to make those changes, it takes testing and ensuring that minor ways of reporting the same information. I just, gave an example a minute ago of, before there might have been category A is 1 through 10 and category B is 11 through 20. And we're going to change that so category A is 1 through 15. Minor little change, but now you've got to go find everywhere in all of your disparate systems, some homegrown, some from a third-party vendor, and change that so that the report now is accurate that you then send out. All of that takes time, and the faster you do it, the more prone you are to error. And so making those kinds of changes this quickly, it just doesn't seem to make a lot of sense. And then to make matters worse, the public's not able to see much of this information that we were able to see before. And so you've got lots of academic groups and journalists who are looking and trying to draw their own conclusions to confirm what the government is saying, or various state and the national governments are saying. And now we don't have those data points. And so it is doesn't seem like a positive move. Might have been well-intentioned. I don't know. And again, all of these updates, you could always make things better, but what is the benefit versus the downside? It would seem one way of making this a little bit less severe would be to say, okay, now we're going to start collecting some additional information, but we're not going to change the current information that you're sending us. And there's a lot of room for improvement, and certainly some folks think that the whole point of this was nefarious, and for the government to be able to control the data so that they could tell us, what they want us to hear, and we don't have a way of checking that. I don't know how much how much that's true or not, but they're not helping the situation by not being more transparent.
Yeah, so I think in the, is it Ebert and whatever, I'm sorry, I can't remember. It's a 2 thumbs down from this.
Yeah,
Rogers.
Yeah, I think that was it. I would definitely give this a thumbs down.
And not just for the obvious reasons of, this is an important time, we shouldn't be doing things like that, but obviously all the changes, and you sort of highlight that. Well, that brings me to another area that, is of equal concern, of the blocking of information. We talk about or hear about information blocking. What's going on around that?
So information blocking is really a relatively new term. It seems pretty self-evident what that means, not allowing information to flow. And with respect to what we're kind of focusing on, is healthcare information. And the federal government has been putting out, or recently put out, finalized rules about how certain healthcare information that various organizations, providers, so that means hospitals and doctors' offices, and third parties like health information exchanges, certain information has to be shared to patients via different ways, and it's really been informal. If you came and said, if I went to my doctor and said I want my records in electronic format, A, they may not have it, and B, they might give it to me in a way that I don't want it, and then that doesn't help me as much. So now there are rules that are starting to come into effect November of this year. And a year and a half after that, there'll be even more rules with more information that physicians, if you have it at hospitals, if they have information in electronic format, have to release it, and fairly quickly. And there's a lot, as with everything with the federal government, with policy, you really need to be a lawyer to come, and which I am not, to come to your final conclusion about what this means. But I think as a summary, most organizations are looking at this and saying, okay, we now need to release patient results from labs and X-rays and MRIs immediately when that information is finalized to the patient via various electronic ways. And we must now, this is new, release notes that physicians write to the patient. So, you've got daily progress notes when you're in the hospital. You've got clinic notes when you go to see the doctor. There are lots of different kinds of notes, operative notes and history and physical notes that are going to be releasable fairly immediately, as most people are interpreting it, electronically. Now, how do you get it? Through various sorts of interfaces. The government's been fairly prescriptive. I think most patients are probably going to get it through their patient portal if their doctor's office or hospital has that. But it's really going to change and kind of turn upside down. I think most places don't share that information without you either A, requesting it, or B, without them kind of selecting which information you're going to get. And the government's been very prescriptive about if you're not going to release the information, why you're not going to release the information. So you don't get to use the typical reason that I like to use for whenever I don't do something that someone wants me to do, because. That's my main reason, because that is not an allowable reason. And so you have to come down with, well, I think there's a patient safety issue, which is another favorite reason. Well, the government says, oh, patient safety issue, great. We have a bucket for that. Now, have you met? And then they show you 7 or 8 different things that you have to meet, or a combination of requirements to establish that there's actually a safety issue for not releasing this lab result or this note. And it's going to require hospitals, doctors' offices, insurance companies to radically, I think, rethink what they normally do. And again, there are some places that are more ahead of this. I think we've talked about open notes before, which is the concept of sharing your progress notes with the patient. And there are a lot of studies and more coming out that's a positive thing, that people that look at about their information, they find mistakes, they they see things in a different way that they didn't exactly hear. I know that's been true for me when I'm in a doctor's office. Even though I'm a physician, I sometimes miss certain pieces of information. When I go back and look at the progress note, I can see more and
it's interesting.
The bigger
I think
picture.
One of the things that comes out of that is that, just from a statement of fact, putting in the notes, and I'll pick an example, it's a bit emotive, but, patient is obese. And, that's not a pejorative statement, it's a medical statement, and it's really important. And sometimes it takes seeing it in black and white to sort of help people transition from the denial that I think we all feel through some of that. And, I've been a big fan. It's interesting. I've seen just, all ends of the spectrum, particularly on a listserv that I'm on that has a lot of physicians of, there's no way we're releasing results. Oh, my God, this is just total disaster. Patients will ask questions. Shock, horror. Patients will ask questions. That's terrible,
It's a horrible thing. It's a horrible thing when patients are engaged in their care.
And I think what I'm hearing is it sounds like, whilst there's still the policy and the challenges around, the construct of this, that the new regulations, which you said November, right? That's the activation.
They start.
That's when they start. We're going to see the rollout of this. And, certainly I, as a patient, applaud that, because some of the instances of the fights I've had to get I used to carry around a fax or a printed note from the ombudsman saying, you are required to do this because it was the only way that I could get it. And there's a little bit of fear, I think. So, he wants it to sue me, I think is what some people perceive. But I want to keep my notes because I'll always have them. And I've had them all around the world.
Yeah. And at least in the U.S., you've always, theoretically, you've always been able to get them. But you had to jump through hoops. And, you had to go to a special place and you had to pay some money sometimes, often, and they were in all kinds of disorder. And now it's going to be, electronic and you're there and you shouldn't even have to ask. It'll be there as long as you have the right program.
Fantastic. Yep. Well, as usual, we've run out of time. We didn't get back to face coverings, but I'm just going to say wear a face covering when you're out and socializing, no matter where you are. Just remains for me to thank Craig, face masking Joseph, for joining me today.
And again, my pleasure. And I want to second your recommendation. Wear a face mask. It's a silly little piece of cloth, and it significantly decreases the risk of you spreading COVID-19 or any other virus. Doesn't make it zero, but it makes it really low. So do it.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at DrNick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com. And tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.